Date that we're looking today, that's going to be the following week.
The lab report will be due the following week, the 27th. Yeah. So the lab report that is due
That's going to be 10.
this Wednesday, like in 2 days, is on the teeth, the dental one. Then the lab report due on the 27th will be the throat and skin microbiome. Yeah. Okay. So when we left off last week, we were talking about Neisseria, and we talked about Neisseria gonorrhoeae. Today we'll talk about Neisseria meningitidis. And so this is the one that we're looking for on that chocolate agar plate. So just like the bacterium that causes gonorrhea, Neisseria meningitidis is a gram-negative diplococcus. And as you might guess by the species name, it mostly causes meningitis. So it is a member in some people of the normal microbiome in the upper respiratory tract, but if it gets into the body, it can cause meningitis. The symptoms of meningitis, really regardless of the cause, are pretty classic. A headache, a stiff neck, intolerance to light, and fever. Unfortunately, meningitis is a very, very dangerous disease. Generally, regardless of the cause, nearly 100% fatal if left untreated. If caught early enough and treated, this type of meningitis specifically, the mortality will drop to 10%. It's a bacterial infection. There is some antimicrobial resistance, but not a ton. So if caught early enough and treated aggressively enough, the fatality rate will drop a lot lower. This is one that we tend to see in young adults more frequently than we see in maybe like infants and the elderly. So this bacterium will go around places like dorms. So they often recommend getting vaccinated prior to moving into the dorms. And I remember when I was in high school, a gal that had graduated a couple years before us was traveling in London, and she was staying in a hostel, and she got this and she died. And so it's very, very quick. It hits otherwise young, healthy people. So it's very important to be cognizant of meningitis. And then, of course, every time I wake up with a stiff neck, I'm like, ooh, no, I'm just old. Okay. You have to have that moment of like, do I have meningitis or am I old? Did I sleep on the wrong pillow? It's the wrong pillow. Sometimes this bacterium can also cause septicemia. So it can get into the bloodstream. It can travel throughout the body. And when it does that, we can see these hemorrhagic lesions appear all over the body. What you're looking at is that disseminated intravascular coagulation. So you have kind of this, I don't know, it's almost like, what's the word I'm trying to think of? Where you're like, that doesn't really make sense. You have a ton of blood clots forming, all these little blood clots forming all over the body. That's disseminated intravascular coagulation. But because all of the platelets are being tied up in causing those blood clots, you also get a lot of internal bleeding because you can't stop bleeding, because all your platelets are tied up forming blood clots somewhere else. You can get shock, right? Overstimulation of the immune system, especially because these are gram-negative bacteria. They have, it's not LPS, right? It's the LOS, the lipo-oligosaccharide, but they still have that lipid A component, the endotoxin, which can overstimulate the immune system. And it can also lead to destruction of the adrenal glands. So untreated Neisseria meningitidis infections can progress and cause very, very significant disease. Humans are the only known carriers. So this isn't something, it's not a zoonotic infection. It's not maintained in animal cycles. So generally us, and this is why we, look for this when we check your throat microbiome, because we don't actually know how many people carry it asymptomatically, but it's estimated that anywhere from 1 to 40% of the population could be asymptomatic carriers of this bacterium, especially in the oral and nasopharyngeal areas in children and young adults. So, y'all are kind of like the peak population where we tend to see this being carried. So that's why we look for it when we're going to swab your throat. We might as well look for lots of stuff because we touched your tonsils, right? We should look for as much as we can with the one tonsil touch. So this is the other thing that we'll be looking for. Again, generally, if it does get outside of where it's supposed to be, it can be cleared by antibodies. But in some patients, for whatever reason, it will go to the central nervous system where we don't really get a lot of antibodies circulating, or it can cause the septicemia before the antibodies develop. So for most patients, if it tries to be naughty, you can stop it, but in some, it will disseminate a little too far. And so we have high spread in close quarters, young adults in dorms and barracks, so people who join the military, also in prisons. And those might not be young adults, they could be all different ages of adults, but people who are in close quarters, you tend to have higher spread. Most common in young people, so we tend to see Neisseria meningitidis more commonly in the young. However, the immune compromised and elderly patients, if they are exposed to the bacterium, are at high risk for developing severe complications. But in the elderly and in children, we often see more Streptococcus pneumoniae meningitis. That's why those age groups are vaccinated against pneumococcus, whereas people your age, young adults, are generally not vaccinated against pneumococcus, but you are recommended to be vaccinated against meningococcus or Neisseria meningitidis. So this is a previously healthy 18-year-old man, like the peak, right, person we're looking at, a young adult, who presented to the ER with acute onset of fever and headache, had an elevated temperature, he had an elevated heart rate, so tachycardia is an elevated heart rate, and he had hypotension, so he had a low blood pressure. So these 70/40 is pretty low. Petechia were noted over his chest, so that's like broken blood vessels, and you can see that, so that's what we're looking at. Although the result of the CSF culture was not reported, Neisseria meningitidis was recovered in his blood. Despite prompt administration of antibiotics and other support measures, the patient's condition rapidly deteriorated, and he died after 12 hours after arrival in the hospital. This patient illustrates the rapid progression of meningococcal disease even in healthy young adults. So it's one of those that even if you catch it, sometimes aggressive therapy isn't successful. So it really depends on the overall host, their immune status, their health, how they responded. Potentially, some of the patient's symptoms could have been caused by his robust immune system because he is a healthy young adult. And maybe that's why his disease progressed so rapidly. Maybe he was exposed to a high dose of bacteria. It's really hard to say why one patient might die and another might not. But those of you working in a clinical setting, if you suspect something like meningitis, it's really important to begin prompt treatment, because it's almost a guarantee that without prompt treatment, they will die, but with prompt treatment, you may be able to save your patient. So really be aware of meningitis. So to diagnose the infection, you can do a gram stain of the CSF. So of course, normal CSF should have no bacteria in it. But we've talked about some bacteria already that cause meningitis. We talked about some of the streptococcal species, like Streptococcus pneumoniae. We also talked about Streptococcus agalactiae, which can cause meningitis in newborns. We talked about Listeria that can cause meningitis. Now we're talking about Neisseria that can cause meningitis. Right? So the streptococcal will be gram-positive coccus. Listeria would be gram-positive rod. Neisseria would be gram-negative coccus. So being able to do an accurate gram stain, as long as there are enough bacteria for you to see, can be diagnostic or very, very close to diagnostic. You might not know whether or not it's strep agalactiae or strep pneumonia, but you know it's strep. Okay. So being able to do that is really helpful. You can test for capsule antigens. So they do have a capsule. You can do serology to look for the antigens. You can culture it from the CSF or blood. So remember, they're not saying they got a negative result from that patient's CSF. They were saying that the results weren't reported. So in the clinical write-up, the authors of that write-up did not specify whether or not they even tried to culture from the CSF, but they did say they cultured from the blood. So you have to be careful sometimes with those papers, like a clinical study, what did they report? What didn't they report? What should they have reported that they didn't report, and where were their negative results? So think about all of those things. What are you looking for as the clinician? So antibiotics generally will work. Remember, there is some inherent, like standard penicillin resistance, but penicillin G is a modified penicillin you can try. Other cell wall inhibitors work as well. And there are a handful of vaccines available. So especially, again, those of you who might work in pediatrics, generally pediatricians might see a patient up through, late teens, early 20s. So you might recommend that. Or if you get a patient in who's transitioned from the pediatrician and is now seeing a general practitioner, you can recommend this vaccine. Or if you go to pharmacy school and you're the pharmacist, you can say, hey, get the vaccine, because your pharmacists usually give vaccines too. Okay, questions about Neisseria. Again, really the diagnostic feature you're looking for, gram-negative Diplococcus. If you see that, it's very rare to see any other gram-negative coccus. Most of them are anaerobic. So if you find one that's aerobic, you're almost certainly looking at Neisseria. Okay. Any Neisseria questions? Okay. So our next genus is Haemophilus. There's one major species that we see in Haemophilus that causes infection in humans. Haemophilus influenzae is the most common. There are other bacteria that fit into this group that is considered the Haemophilus group. We don't talk about all of them because they're not all terribly common. But this one I do like to say, Aggregatibacter. It's one of my favorites just to say it. And Actinobacillus and the Aggregatibacter often can be associated with actinomyces, so like oral infections. So if you're interested in dentistry, these might be some that you can come into contact with. Pasteurella is another one that isn't terribly common. It's not super rare either. We tend to mostly see Pasteurella infections associated with animal bites. So if a patient comes in and has been bitten by a domestic animal like a dog or a cat, that's one you could look into. You also worry about rabies, but bacterial infections, Pasteurella is one that sometimes is in there. So Haemophilus will also grow on chocolate agar. So it's entirely possible that some of you carry Haemophilus in your upper respiratory tract because it is found on mucous membranes. And it may have grown on that chocolate agar. So some of the growth factors that we have in chocolate agar that help support the growth include hemin. It's basically because you've cooked, it's cooked blood agar. Because you've cooked the blood agar, you release some of the compounds that are typically found in the red blood cells. So it makes it more accessible for them if they are not able to break down the red blood cell. And they also require NAD, supplemental NAD. They can't make their own. So I don't know why it doesn't say it on here. Why did I forget? They're gram-negative, by the way. They're gram-negative rod-shaped organisms. So the species that's most common is Haemophilus influenzae. It does have a polysaccharide capsule, and it has what we call 6 serotypes. And so basically a serotype is the antigenic profile, and you'll get a very specific type of immune response to the different antigenic profiles. So they can be classified by serotypes, and the serotypes with Haemophilus are given letters. So Haemophilus influenza type B, so serotype B, is the one that's implicated in 95% of invasive Haemophilus influenza infections. So type B is the dangerous one, is the way we can think about that. So we'll remember that, Haemophilus influenza type B. There are some strains of Haemophilus influenza that actually don't produce a capsule. There's also a closely related species called Haemophilus parainfluenza, that they are the ones most commonly associated with part of the microbiome. They colonize the respiratory tract relatively early in life. And even though they are unencapsulated, less virulent than that type B, they still can cause infections. But typically, when we see things like otitis media, a middle ear infection, sinus or lower respiratory tract infections, we're seeing those because something in the patient has already gone wrong. And this is more of an opportunistic type of infection. So maybe it's a child with allergies, or a child with some sort of viral infection, or a child who's already had a different bacterial infection. And that susceptibility, because of already being sick or already having like the immune system stimulated, can lead to the less virulent strains causing some manifestations of disease. When we look at the encapsulated strains, so the ones that actually have a capsule, those are the more common causes of disease in unvaccinated children. And they also are a little bit more dangerous when they cause disease. And so when these encapsulated strains infect a patient, you can often see something like meningitis. So now we have a gram-negative rod that can cause meningitis. Usually what will happen is this is mostly in children, the child will experience 1 to 3 days of classic upper respiratory tract infection symptoms, cough, sore throat, maybe slight difficulty breathing, before they develop the symptoms of meningitis. And just like with Neisseria meningitidis, with treatment, we can lower the mortality rate to about 10%. Now, one of the things that this bacterium does that we really only saw with Corneobacterium diphtheriae is this bacterium, Haemophilus influenza, causes swelling of the epiglottis. And remember, the epiglottis is that tissue that protects you from inhaling your food. It blocks the windpipe as you're trying to swallow food or drinks to keep you from aspirating whatever it is you're trying to consume. So they're showing you in this picture in panel A on your left, you have a normal epiglottis, and on the right, you have one that's clearly very swollen, and you have a patient who's been intubated. Now, the challenge here is if you do have severe epiglottitis, severe infection and swelling of the epiglottis, your patient can suffocate because it blocks their windpipe and they can't breathe. So in your pediatric patients, when you see swelling of the epiglottis, really the only thing you can do is intubate to protect their airway and allow them to breathe while they try to fight the infection. But you have to be very good at intubating, because if you don't do it right the first time, you risk it swelling up right then and blocking the airway. So you have to be really good at doing intubation in your pediatric patients. So this is one of the few, even diphtheria doesn't do it this badly. With diphtheria, what you can sometimes see is that pseudomembrane will form and block. But with Haemophilus influenza, you're getting swelling of the epiglottis. And again, it's one of the few that does that. So that's a really big sign that you're looking at Haemophilus influenza infection. It can also cause cellulitis in the face. So if somehow the bacterium is able to get out of the respiratory or kind of the oral cavity, it can cause skin infections. That's basically like just beneath the skin. Or it can cause arthritis in the large joints. So here we have a 61-year-old woman with pneumonia caused by Haemophilus influenza type D. So this is not the most invasive form, but it is one of the encapsulated dangerous strains. So she's one of those patients that you're like, you'll treat her because she's your patient. You want her to get better. But she's not doing any favors for herself. History of smoking, chronic obstructive lung disease, diabetes, and congestive heart failure. Those are your patients that are like, I have lung cancer. Why do you want me to stop smoking? Okay, it happens. So she presented with left upper lobe pneumonia. She had a purulent sputum, so it's full of organisms, with many gram-negative coccobacilli. So they're gram-negative. They're not as long as some of the other gram-negative rods that we're going to cover in the next section. So they're kind of the short rods, just like listeria, short rods, but these are gram-negative. So you can either call them short rods, you can call them coccobacillus, whatever. The sputum and blood were positive for Haemophilus influenza. I'm sure they did some other serological tests to determine that it was type D. The organism was susceptible to ampicillin, to which the patient responded. So her risk factor, so even though type B is the one that's typically associated with invasive infections, which is what she had to cause pneumonia like that, her underlying pulmonary disease made her susceptible to an infection that was not a type B. And, looking at the year 1983, right, this is also prior to type B vaccination. So when you have a patient who tests positive for Haemophilus influenza, especially nowadays, they're almost certainly not going to have type B, but they probably have some underlying health condition that has made them susceptible. So that's what you have to look at as well. And the trick with these patients is they'll turn up with one of these infections, you'll treat it, and if they don't work on the underlying conditions, they're going to keep coming back. It may be the same infection, especially if it's endogenous from their own microbiome, or it may just be whatever they get exposed to next. So the bacterium has adhesins that help it stick to the host. Basically any bacterium that can cause infection is able to stick to the host in some way, shape, or form. It is a gram-negative bacterium, so the cell wall components, right, the LPS, the endotoxin, can damage the epithelium, can allow it to become invasive and get into the blood. The capsule, as with most capsules, is antiphagocytic, allowing for immune evasion. And of course, that lipid A can also induce inflammation. And to top it all off, it also will have IgA proteases to interfere with your humoral immunity. Remember, IgA is that super important secretory antibody that protects your mucous membranes. So now you're at risk. So this used to be a relatively common infection, especially the invasive type. There were over 20,000 Haemophilus influenza type B cases in children under the age of 5 before vaccination in the US. The most recent data I could find were from 2020. There were only 19 cases in children under 5. So the vaccine works pretty well. If you have children or you're planning to have children, the vaccine is called the Hib. The pediatrician always forgets that. She's like, what do you do again? I'm like, I teach med micro. Oh, yeah. Okay, I don't have to tell you about this. I'm like, no, it's good. But now you don't have to, obviously I'm a microbiology expert. I know what Hib is. So now you know what Hib is if you go to the pediatrician. But still, vaccination is not always practiced worldwide. Some countries just don't have access. They don't have the infrastructure to support the large-scale vaccination programs that we have in the US. So worldwide, 3 million cases, 700,000 deaths. So it's a lot. And these are mostly children under the age of 5. As you may expect, because we have a vaccine against type B only, the other infections haven't gone away. And so now what we tend to see is that if a patient does have a Haemophilus influenza infection, it's usually not type B. The other strains are more common, or other species of Haemophilus are more common. And by that, I don't mean that more people are getting Haemophilus infections. I just mean that the ones that are getting Haemophilus infections are not getting influenza type B. They might get type D or parainfluenza. It's just the other species are more common now, and the other strains are more common now than type B. Okay. There are other Haemophilus species that can cause infection. Haemophilus aegyptus can cause conjunctivitis, pink eye. There's a species, Ducreae, that causes genital ulcers. But again, we're mostly looking at Haemophilus influenza as the most common species. And then here are some of the infections that are caused by various Haemophilus species. So meningitis, conjunctivitis, sinus, right, cellulitis, middle ear infections, the epiglottitis, pneumonia and bronchitis, and arthritis. So there are a number of different manifestations of this infection, but generally it's not terribly difficult to culture. So as long as you're growing on chocolate agar, it will grow. It's not that picky. Chocolate agar isn't difficult to make and not hard to come by. A gram stain of the cerebrospinal fluid can be diagnostic in meningitis. So now we've talked about gram-positive coccus that causes meningitis, gram-positive rod that causes meningitis, gram-negative coccus that causes meningitis, and a gram-negative rod that causes meningitis. So in theory, if you were given a gram stain of somebody's cerebrospinal fluid, you should be able to identify the most likely cause of that patient's meningitis. Sure, it might be something weird, but I'm not gonna, make it something weird on the exam. It would be one of the most common ones. Okay. So that gram stain of the cerebrospinal fluid can be diagnostic. You can also look for the polysaccharide capsule antigens. Untreated meningitis or epiglottitis has a mortality rate near 100%. So yes, you can do antigen tests, and if your lab has a rapid antigen test, that's great. But if it's not a rapid antigen test, you may want to look for a gram stain. And really, if you see epiglottitis, and I would just say it's Haemophilus. It's pretty, and no pseudomembrane. You see a swollen epiglottis, but no pseudomembrane. It's not diphtheria. It's Haemophilus. Different antibiotics work. Cephalosporins, amoxicillin, erythromycin can treat the various infections, and vaccination can prevent against the most serious strain of disease. So Haemophilus influenza type B, the vaccine will protect. And this vaccine, I don't remember exactly when it was developed, but it was not around when I was a kid. Really, once a patient makes it past about the age of 5, the risk of serious infection without any underlying complications is pretty low. So this is what you would want to use to protect your infants. So if you've made it this far, you're probably okay. If you end up immune compromised or with other kind of underlying conditions, then you may want to see if you can get vaccinated. Questions about Haemophilus. Haemophilus, I have a little soft spot for it. It was the first bacterium that was ever sequenced. I don't know why they picked Haemophilus, but they did. So if you take genetic biotechnology, you'll get to learn all about sequencing. And I'll tell you all about that bacterium. Okay. For the rest of today, we'll talk about some of the Enterobacteriaceae. So this section is pretty much all about diarrhea. Because, yeah, it's all about poop. It's poop. It's a good lunchtime class, isn't it? I don't know how this class always ends up being scheduled at noon. Like, yay, poop. So, Enterobacteriaceae is a family of bacteria. They are gram-negative rods. The majority of them are gastrointestinal pathogens, though there are some that are not. They are found worldwide in soil, water, and as part of the intestinal microbiome. And there are some that are always associated with disease. There are also some that would be considered opportunistic. They don't always cause disease, but they can if there are too many of them, or they get in the wrong place, or they produce a particular toxin. So some of the common members of the Enterobacteriaceae are listed here. You might recognize some of these names as bacteria you worked with in bacteriology. Enterobacter, E. coli, Klebsiella, Proteus, Salmonella, Serratia, Shigella. There are others that you might not have thought were actually part of this gastrointestinal group, like Yersinia pestis, which causes plague. But there are other members of Yersinia that do cause gastrointestinal infections. So a common misconception that I sometimes see is that some students will think that every bacterium that causes diarrhea belongs to this group. And that is not the case. So a lot of times students will say things like Vibrio, which causes cholera, belongs in here because it causes diarrhea, right? So this is a taxonomic classification. Only these organisms belong in this group. Okay, so just because it causes diarrhea doesn't mean it belongs in here. Most of these do cause diarrhea. So really, like, kind of try to keep that distinction as clear as possible. Just because it causes diarrhea doesn't mean it belongs here. This is these are genetically related. It's a taxonomic, it is a family of organisms. So they are all very closely related. They are of moderate size, so you probably remember looking at things like E. coli under the microscope. They don't form spores. Gram-negatives usually don't. That's usually a gram-positive thing. They have a common antigen. These are genetically related organisms. So they have a common antigen that we call the enterobacterial common antigen. For the most part, they are rapid growing. In a laboratory setting, they can replicate every 15 to 20 minutes. They grow quick. In the body, it's a little bit slower, but it's still pretty fast. They're mostly facultative anaerobes. They prefer oxygen. They do fine without it. Facultative anaerobes, which is why you can often find them in the GI tract, right, where there isn't oxygen available. But you can also find them in soil where there's a ton of oxygen. So they are facultative anaerobes. They are relatively easy to grow. They have pretty simple nutritional requirements. We don't have to use specialized media to grow them. You might remember that we typically cultured them on special media, but that was just so we could tell them apart. Not that we needed special media to make them grow. They'll grow on nutrient agar, they'll grow on LB, like any kind of basic agar, they'll grow. They don't need anything special. They are oxidase negative. And you might be having flashbacks now to your dichotomous key. Some of the gram-negative rods are oxidase positive, but members of this family are oxidase negative. So something like Pseudomonas, you might have been like, oh, it's blue, it's Pseudomonas, but then you double check and make sure that it's oxidase positive, because that's Pseudomonas. The other gram-negative rods that belong to this group are oxidase negative. So in general, this is kind of what a cross-section of a member of the Enterobacteriaceae may look like. Many of them have flagella for motility. Many of them produce a capsule. When we start to name the different strains of the species, we tend to name them based on the antigens they have. So you have flagella, which is H antigen, capsule, which is usually called K, and then you have the O antigen, which is their polysaccharide. And that will differ between different members of the same strain, different members of the same species, and different species will have slightly different O antigens. And so I said we sometimes use these to name the strains. So maybe you've heard of E. coli O157H7. That's the one that is usually found in contaminated food products that causes invasive gastrointestinal disease. So it has the 157 version of the O polysaccharide, and it has the 7 version of the H antigen, the flagellum. E. coli K12 has a particular capsule. It can sometimes cause neonatal meningitis. Okay. So different genera differently ferment lactose. So you might remember, like when you put E. coli on an EMB plate, that thing ferments lactose like gangbusters. It turns that brilliant green color. We don't trick you too much. We only give you one that turns green. Citrobacter is another genus that will actually turn green on EMB. So there's a couple that ferment lactose like really well, and then others maybe less well, or maybe not at all. They have different resistance to bile salts, and they may or may not have a capsule, so we can differentiate them. The LPS, of course, is their major cell wall antigen. They are gram-negative organisms, and their classification, like I mentioned, is based on those H, O, or K antigens. Flagellum is H, lipopolysaccharide is the O, and then the K is the capsule. Again, most are motile. The level of motility differs depending on the species. Something like Proteus mirabilis, I mean, it's like, it is so motile you can actually watch it move. Like it spreads across the plate so quickly. Maybe that's an exaggeration a little bit, but it's pretty fast. Okay. They have peritricious flagella. They are covered in flagella over the whole surface. Many have pili for adherence. They're sometimes called fimbriae. Others can do conjugation. They'll form a sex pilus or a conjugation pilus for the exchange of genetic material. So these are really well evolved to be pathogens. So some of the common virulence factors, they all have endotoxin, right? They're gram-negative. Many have capsules. They have what's called antigenic phase variation. They can change their surface antigens. One that does this really well is Salmonella. They have, oh, okay, I'll try again. They have what are called type 3 secretion systems. This is basically a modified, it's like a modified bacteriophage injection apparatus. So they make, if you picture like a syringe, they make their own syringe. They stab neighboring cells or they stab a host cell and inject their proteins or toxins directly into the host cell. They can steal your growth factors. They're often resistant to killing by complement, and they have high levels of antibiotic resistance. And there's your type 3 secretion system. So see, it looks like a little needle. These two membranes belong to the bacterium, right? Here's the outer membrane, the inner membrane. It makes a needle, it stabs the host cell and injects whatever proteins or toxins or compounds into the host cell. It's pretty creepy, right? This little bacteria coming around with a needle trying to stab you. Okay. Questions about the Enterobacteriaceae broadly before we move into particular species. Okay, so E. coli is probably the one that you've all heard of. Might be the first bacterium you ever heard of when you started taking science classes. Very, very well characterized, very well studied, and a very effective and efficient pathogen. It is responsible for causing approximately 80% of urinary tract infections, tons of hospital-acquired infections, and gastroenteritis. So I believe this is from a hospital setting. They tried to break down which members of the Enterobacteriaceae were most common in causing infections. You see, E. coli accounted for nearly half of all the infections. Okay, and then other genera. So causes a lot of different kinds of infection, and the majority of infections are endogenous. E. coli is typically a member of your gut microbiome. So especially with urinary tract infections, it is from your own bacteria that got into your urinary tract. So this could happen in a hospital if you were catheterized. Sometimes when they place the catheter, fecal bacteria can get in there if they don't clean it well enough. Or depending on your own anatomy, if the urethra is closer to the anus, more likely. If it's farther away, less likely, which is also why we tend to see urinary tract infections be more common in females than males because of the anatomy of where the urethra is. With males, it's pretty far away. With females, it's a lot closer. If you have a lapse in hygiene, whatever. It's not uncommon for fecal bacteria to get into the urinary tract, and E. coli is really good at establishing itself in there and causing infection. So in terms of GI infection, though, we typically associate E. coli gastrointestinal disease as being exogenous. You consumed something that was contaminated with the bacterium. Usually your own gut microbiome is not going to give you a gastrointestinal infection. Your own gut bacteria aren't going to make you throw up or aren't going to give you diarrhea. It's somebody else's gut bacteria that will do that. Often that somebody is an animal. So generally we're talking about food or water that has been contaminated with animal feces. We can break down the pathogenic E. coli into which part of the intestine the various strains tend to colonize and cause disease in. So on this slide, we have those that tend to establish themselves in the small intestine. So I'm not going to necessarily ask you to remember all of these acronyms and remember all the details about all of them, but it is important that you remember there are different kinds. We can differentiate them in kind of major ways. So E-tech is one of the most common. So it's enterotoxigenic E. coli. They'll sometimes call it traveler's diarrhea. You went to another country and you drank the water and you got diarrhea. Traveler's diarrhea. Generally, we call it enterotoxigenic because the symptoms are not caused by the bacterium themselves, they're caused by toxins that the bacteria produce. So they have two different toxins. One is a heat stable, they call it ST. One is heat labile, it's destroyed by heat, call it LT. And the majority of US outbreaks of this are caused by the heat stable toxin. your symptoms are going to be traveler's diarrhea, infant diarrhea in developing countries. We're going to talk about different kinds of diarrhea. So this is going to be watery diarrhea associated with vomiting, cramps, low-grade fever. For the most part in the US, the majority of our gastrointestinal infections cause watery diarrhea. It's what you think of when you think of diarrhea. Okay. There's enteropathogenic E. coli or EPEC. That's infant diarrhea in developing countries, usually not as much in adults. It's pretty rare. It causes non-bloody diarrhea, so you have watery diarrhea and vomiting. What happens here is you have a plasmid that disrupts the microvillus structure. And so instead of having these really nice like microvilli where you get good fluid absorption, right? That's why you have all these like projections in your intestines. You have more surface area to absorb fluids. So it changes how those look, and it decreases the amount of surface area. So you can't absorb as much water. The water has to go somewhere, and so it goes out. With improved sanitation, we don't see EPEC very much, but again, in developing countries, so places that don't have the same ability to have clean water. Enteroaggregative E. coli also manipulates the microvilli. It causes them to be kind of covered in the bacteria. You can actually see the rod-shaped bacteria covering the microvilli, which blocks absorption, and it also causes them to shrink, which blocks absorption. So infant diarrhea, they say probably in developed countries, traveler's diarrhea. This is persistent watery diarrhea, vomiting, dehydration, and maybe a fever, because you can get these to infiltrate in the intestines a little bit. You get infiltration of white blood cells. You can get hemorrhage, so you get maybe a fever in this case. So those are your small intestines. They can also get into your large intestine. So there was one that, back in my day, when I took Med Micro, there were 6 different kinds of E. coli that we talked about. Now we only talk about 5. One of them got kind of lumped in. So the other one we used to talk about was EHEC, enterohemorrhagic E. coli. So we put it under this line here, STEC. This is one that you worry about. So it's Shiga toxin producing E. coli. This is again in the large intestine. Initial watery diarrhea followed by grossly bloody diarrhea. You can see the blood in the stool. And that is because you have Shiga toxin destroying the cells of the intestine. So you have tissue destruction. So hemorrhagic colitis. So the toxins cause lesions and destruction of the intestinal microvilli, decreased absorption, cytotoxic Shiga toxins, which disrupt protein synthesis. Little to no fever, may progress to hemolytic uremic syndrome. So it can move from the intestines into the bladder, either through invasion or as a urinary tract infection, and cause damage to the kidneys. And we'll stop right here and pick up with enteroinvasive. I'll actually put that on a video. But right now in Canada, there's an outbreak of STEC in daycares. Like almost 200 kids at daycare centers around Alberta got it from a common food source. So this is your O157H7.